the conversation around an autism diagnosis. First, the importance of being thorough and doing a comprehensive evaluation. But then second, it's not about just labeling a child. It's about talking about what the needs are going to be and how the autism presents itself and affects other parts of development, because it's different for every child. So when giving an autism diagnosis, it's really important that we...
Hello, and welcome to Unoverwhelmed Emotional Fitness. My name is Elvia Diaz, and I am a proud mother and advocate and a coach for families of children with autism or neurodiversity. In this channel, we share reflections, tools, and real-life stories that bring hope, emotional strength, and faith on this neurodiversity journey. My goal is to help parents and caregivers feel less overwhelmed and more empowered as we walk this path together. Thank you for being here, and let's take a listen. Hello, everybody. Welcome to today's episode. I am so excited because we have a very, very important topic, which is understanding the diagnosis of the autism spectrum disorder. Many of you have asked for this topic, and finally, we were able to get Georgina Lynch. She's a PhD, and I will post part of her curriculum on the description. But I can tell you that she's a renowned researcher, clinician, and advocate in the field of autism and neurodevelopmental disorders. She holds an interdisciplinary PhD in neuroscience and psychology, and she's also licensed in speech language pathology, nationally certified by the American Speech Language Hearing Association. With over 20 years of experience, Dr. Lynch has dedicated her career to assessing and treating individuals with autism spectrum disorder and other neurodevelopmental conditions. And now she's also working as a research for biological aspects of autism, which will be in future video. But today, please welcome Dr. Georgina Lynch, who is a very dear friend, and I know that you're going to learn a lot. So please stay. Georgina, thank you so much. I'm so excited that we have you here today again. Again, you're such an asset to the channel, and we so much appreciate your presence here today. A lot of people don't know you, Georgina, but for you, one of my dearest friends, and I'd like to introduce you to those who have not had the pleasure to knowing you. Could you tell us, please, a little bit about yourself?
Sure, I'd be happy to. It is great to be back on this series, Elvia. Thank you for having me today. So I am a speech pathologist by training. I also hold a PhD that is interdisciplinary in psychology and neuroscience, and I'm a researcher specializing in autism spectrum disorder. I currently am involved in developing medical device technology to help with early detection of autism, and I've treated children with autism and evaluated them for the last 20 years, and that's informed a lot of my research. So I'm here today to talk about some of the challenges that our families go through when seeking a diagnosis.
That is why you are just so pertinent to our channel, because you have worked with the families as a speech pathologist, and now creating this technology, which I am going to have your promise here. Once we have that more mature, you're going to share with us, right?
I sure hope so. Yes.
That would be just so wonderful, because I know that's in the making, and I'm just so excited with that, but it's yet to come. Okay. So it's wonderful that we're here. And today we we're going to have you here speak about, most importantly, understanding the ASD diagnosis, autism spectrum disorder, as a diagnosis. And I would like to, if I may, to share a little bit about my own experience. My son is 21. So, we have had quite a journey with this part of the diagnosis. And obviously today things have changed, thank goodness. But I want to be a little more mindful with people that they should find the answers, but not be afraid of asking the questions. So if I may, I will first share the story. Then I'm going to be asking you some questions that many parents have asked. I asked them, what questions would you ask to a specialist? And these are the questions that I have gathered from them. And then at the end, maybe we can share some more specific resources so that people who are wanting to understand how these diagnoses work can go deeper. Okay, please. This is, of course, this is for people, for beginners.
Yeah.
But who better than an expert to help us beginners? Okay.
Absolutely.
Thank you. For my son is now 21 years old, but when we started noticing different problems and situations, so typically, we thought that he couldn't hear, so we had his hearing tested, and that's when the specialist said that he should be potentially have something else. He didn't mention anything. So then I went. They had his brain scanned. So with this electroencephalogram, it was in Mexico, so it was very difficult to do that. I have shared that journey in another video, but all I got was a CD. So with that, I couldn't know whatever the CD was, and I couldn't wait. So I went to see a neurologist. So he checked the video. At this point, where my son is all over the place in the office, up and down, sitting here, sitting there. Mm-hmm. And the neurologist is checking on the computer, and he says, "Well, I think everything is good." I said, "Oh, good, okay." And he saw my son a little bit, and then says, "Well, we're going to get you started with this." So he gives me the prescription, and I just read there, RDX, autism, risperidone, 0.5 milligrams every Sunday. So, I mean, I just read it. No heads up whatsoever. My son was only 4 years old, and I was like, what? Obviously, I did not accept it because I had no explanation, and so it went there, and then finally I had to go to a psychiatrist, and he said that my son was just delayed, and that we couldn't confirm it yet. But so it was very, very, very stressful, until we finally were confirmed. And I didn't know the difference between an illness and a syndrome. So, that when it could be treated. So the doctor did say, don't worry about that. You are doing the therapies, whichever the diagnosis for your son, the therapies will be the same. But I'm talking that it was a whole year and a half of going with different specialists, trying to do this and trying to fight it. So it was very, very stressful. Of course, when I read that, I'm just recalling the moment when I read that, I felt like a bucket of ice water, just, because I had no idea what the actual word meant. So that was my journey. And I know that many people have gone through that. So with that in mind, could you help us not to feel like that, please?
Yeah. Absolutely. That story, it really resonates with me. I've spoken with so many parents over the years, and the delivery is always, I think people are getting better at that delivery, and the models for evaluation are getting better. But there's still a lot of improvement to do with how we destigmatize the conversation around an autism diagnosis. First, the importance of being thorough and doing a comprehensive evaluation. But then second, it's not about just labeling a child. It's about talking about what the needs are going to be and how the autism presents itself and affects other parts of development, because it's different for every child. So when giving an autism diagnosis, it's really important that we give a comprehensive picture of the child's strengths and their needs so that we can build those supports around what the needs are. It's not just about that label. So I'm sorry, to hear your experience, to receive it on a piece of paper like that. And I've had other parents tell me similar things. Well, your child has autism, don't you? And they did not have any idea, and that's how it was presented. So today we'll talk about that and kind of what best practices are and how it really should look. So we know that the people that are qualified to diagnose autism are typically a neurologist, a clinical psychologist, a physician, developmental pediatrician. And more what we're seeing in the United States is we're seeing primary care providers taking a front and center role around that diagnosis, because you're their first point of contact. You bring your child in for these annual exams. And there's been a shift towards screening for autism in addition to evaluation. So that being said, it's kind of an important consideration that we're looking at the child's whole development, not just looking for features of autism, because sometimes it truly is a hearing loss or it truly is some other issue that's going on. And quite often there might be a genetic condition that's part of this too. So it's not enough to simply observe a child and think that we have all those answers. It should be really a thorough process. And so we can start with, what does that look like? And maybe you want to frame this around the optimal age in which we start asking these questions.
Thank you for bringing that about the age, because as my journey, I was told that back in those days, the only one that could actually give a more accurate diagnosis would be the pedo psychiatrist. Pedo meaning for children, and it was psychiatrist. So it was a whole journey. Thank goodness I was able to have a pedo psychiatrist, which was actually a miracle. I will share that in another time. But he then said that it was best for the, whether Asperger and all those names, to be confirmed until he was 5. Because we should not do it before, because then he could be labeled or misdiagnosed. So, we had to wait until 5 years old to actually have the confirmation of the diagnosis, which back in those days was mentioned that it was Asperger's. But, and you say, oh, it's okay, it's not autism, it's Asperger.
Yeah, so there's a lot. Yeah, there's a lot to unpack there, right? Because now we say don't wait. Please do not wait, right? If we can see the signs of autism as early, to a trained clinician, as early as 13 months, but reliably 18 months, and it's considered stable by 2 years of age. So when the diagnosis is given under comprehensive conditions by trained people, that diagnosis is pretty stable early on in terms of meeting that criteria. So we don't wait for that to happen, because we also know that access to early intervention is an important component. So identifying those features early also lets us offer the supports early and offer that change in service that really can make a difference, because we know you have autism. It used to be said that the treatment would be the same, but we also now know that there are 27 evidence-based practices, and many are designed to be very unique to the features of the needs of your child, as well as offering a parent coaching model to that. So the American Academy of Pediatrics recommends screening at 18 and 24 months for autism, regardless of a parent's concern. So even if you're just coming in for a well child exam, pediatricians are encouraged to be looking for signs of autism, particularly if other developmental milestones haven't been met, like talking or smiling or pointing, gesture use, all of those social communication red flags that can be indicators of autism. So we do know that when you're considering the diagnosis, it's multifaceted. And the current tool that we use in terms of making that diagnosis is the American Psychiatric Association. It's the Diagnostic and Statistical Manual, 5th edition, and everyone kind of knows it as the DSM-5. This is the tool that gives the criteria, the observational criteria that needs to be met. And so what we're doing when a physician is considering an autism diagnosis, they're going to get a lot of input from the parent. That's one part of the process. They're also going to look at the child's behaviors in terms of social communication, behavioral kind of disruption or challenges, and then the presence of restrictive and repetitive behaviors. So when we're considering an autism diagnosis, there are two major domains. There needs to be social impairment, and there needs to be the presence of restrictive repetitive behaviors. Sometimes that is difficult to discern in very young children, and it's difficult to know. So we may see, well, they're not smiling or they're not looking at the familiar caregiver, but they're just shy, sometimes people will say. But then you start seeing as they're playing with toys, well, they're spinning the wheel on the truck, but they're not really playing with the truck, and they're not really engaging with it in the way that we would expect a child to, reach out and show a caregiver, look at my toy and play with the toy. And that begins to start looking like a restrictive, repetitive behavior. In order to meet that diagnostic criteria, you need to have both. And so that's where the diagnosis later in life is more difficult to tease apart as well, because many people have social communication impairment, but it may not be due to autism. It might be due to something else, social anxiety or some other feature. So following the DSM-5 criteria is really the gold standard tool that we use to parse out other mental health disorders or other conditions. For children under 5, we're talking about a neurodevelopmental disorder, and autism typically occurs during that period. And it also needs to be noted that it's not better accounted for by some other reason. That's one of those nuanced things that are really important to think about, because a child who's been through trauma may have features of autism, but it isn't necessarily autism because of some environmental situation that they were brought into, or drug or alcohol exposure in utero, these things that contribute to delays but aren't autism alone. So it takes a very skilled medical provider to take a thorough developmental medical history in addition to looking at that DSM-5 criteria. So there is also a test that's often given when we're considering the diagnosis, and it's called the ADOS. It's the Autism Diagnostic Observation Scale. And that is a play-based assessment where a clinician will be on the floor with the child, parents in the room, and we're eliciting all of the social communication behaviors that we're trying to see, does your child have that? Those are those red flags for autism. When they do not have joint attention, or they're not pointing, or they're not requesting more, and they're not making eye contact. And all of these things get coded during that play-based assessment, and that informs making a diagnosis. So we always like to remind parents, a test alone doesn't diagnose autism, but the ADOS is one piece of that. The developmental history and the information you give is critically important for that physician to make some other decisions. And then we take all of that information, and that information then is mapped onto the criteria for autism. So it should be comprehensive and look at all developmental milestones and how delayed you are from those as well. So I'll pause there because there's more to the diagnostic criteria, but that's the process.
Very, very detailed process. I mean, obviously, as things have developed, now there's at least like protocols that there were.
That's right.
That there were none back in my days, in our days. So I'm going to back up to make sure that I am following you and put this into plain English.
Yeah, there's a lot to it.
Then never mind. No, okay. So the parents, I mean, the nowadays the primary physicians should be looking for the main signs. Okay. Correct. So we're looking at these red flags, and we want to make sure that there is no misdiagnosis, like what you mentioned, like you do know that your child has autism because they see some of the signs and they just assume, which, I mean, if I take back to my story, the doctor obviously had a lot of experience, and in reality, by looking at my son, he already knew that my son had autism, but obviously for me it was difficult, and 2 years later it was confirmed. So even though I'm angry at him, he gave me the first heads up. So I didn't like the way he said it, but he was right. So with these red flags, mainly, like you mentioned, if the social, we should not be paying too much attention to these social interactions that a lot of people mention. Not to pay attention, but it could be misleading if I'm reading that correctly, because it could be for other reasons, like social anxiety and things like that. So it is important, but not the only one, right? So could you?
Yeah, and I want to be clear that it's critically important.
Could we recap on the most important red flags? So because we said it here and there, but if we give the first most important red flags.
So the red flags for autism are lack of gesture use, lack of pointing, lack of smiling, lack of social reciprocity with a familiar caregiver. So if I have a young infant with me and I'm the mother of this young child, and they're familiar to me, right? Because if you're not familiar, they might not do those things. But to a familiar caregiver, I'm not pointing, I'm not smiling, I'm not using social reciprocity, joint attention, I'm not sharing objects and toys with you, and I'm aversive and kind of, not present in that situation. Those are all considered red flags for autism. Those social behaviors are present very early in development. We can use those as kind of markers as early as 12 to 13 months.
Oh, wow.
So the point I was making was a medical history is as important as the observation, because if we know that there was drug exposure or there was trauma in the home or some other situation that might have happened in addition, we have to parse that out and consider it. Autism is only an autism diagnosis in the absence of those other factors. So a developmental history also helps inform that. Sometimes we have parents of adopted children and they don't have that full history, but they know there was that trauma in the home. And so an astute, trained person diagnosing autism would consider that in the makeup of making this decision. So that's what I meant by that other piece. So it is important. Those are those red flags.
Okay, so it is important. All right. I'm glad we clarified that. All right. So, but then again, we're looking for this, but normally it's what we mentioned is comorbid, right? That is not just autism alone, oftentimes it's also with something else like.
So I'll go through that. Yep, I'll go through
Yes.
that. And I think it's
Okay.
really important for clarity. This is a tough thing to describe in a conversation. So it's going to sound like a list when I talk about it, just so that, as you said, we keep it real focused for people. Autism has 3 levels: level 1, 2, and 3. We'll talk about that in terms of how that's defined. It's by the level of support that is needed. But then we further define it based on what are called specifiers. Specifiers mean they further characterize your autism. So it's with or without a language impairment, with or without a comorbid condition, as you were talking about, and with or without a known medical condition or genetic condition. The reason that the criteria has changed to that is because we used to think of autism as this broad spectrum, and now it's helping inform treatment when we're a little more specific about talking about the autism in terms of what support do you need and what other contributing factors to your autism are requiring that support. So if there's a known genetic condition, that also informs treatment. There are a lot of co-occurring genetic conditions with autism features. And sometimes an autism evaluation is the first time that a parent is learning that their child has this genetic condition. If a child has a language impairment and they're nonverbal, we may be looking at that specifier as an important feature of their autism, because that'll be the first thing that we're going to think about for intervention as well. So it's autism level 1, 2, or 3, with or without language impairment, comorbid condition, medical or genetic condition. And what we're doing is trying to conceptualize a profile of a child's need in order to address their support.
Okay, that's great.
That's a lot there too.
Yeah, but okay, so with the levels come from the DMS-5, correct?
Correct.
Okay, because and I want to make the distinction. Let me see, I want to make sure I make this question clear. So the levels come from DMS-5, but some people say moderate, mild, moderate, or severe. Is there a correlation with that? You know, would say severe autism, meaning maybe it's level 3, or there's no correlation?
Yeah, so what we try to do is talk about the level of support and need. So when the criteria were reconfigured about 2013, what happened is they took the spectrum away that included some of those other labels like Asperger syndrome, PDD-NOS, pervasive developmental disorder, not otherwise specified. Then you had autism as another part on the spectrum, Rett syndrome. All of these were considered along a spectrum, and quite often if a physician wasn't sure, they would give you PDD-NOS and say, I don't really know.
Yes. That's what I got. And I was like, what? That just means that
what
they
is
don't know what
this?
they have. Yes.
Exactly. And so your question about level of severity, when they reconfigured this diagnostic criteria, they said, it's all a feature of a continuum of autism, but there are level of supports that are more needed for some than others. So level 1 the new criteria at that time did tend to put people who previously had been diagnosed Asperger's syndrome into that category. Level 1, the diagnostic criteria says it requires support. Well, that's very kind of broad, right? We don't really know what that means, but they do need some support. Level 2 says you require substantial support, meaning maybe we're modifying your classes at school, how we deliver instruction. Maybe we're giving you additional help in terms of communication and social skills teaching, and maybe even independent skills. Level 3 says very substantial support. And what that is that means for almost all daily living skills and adaptive skills, we're going to need to provide substantial support to help you to fully participate in the world and start to work toward your total full potential. They have moved away from the use of mild, moderate, severe, but generally autism level 1, 2, and 3 does characterize the need. It's very difficult to draw a distinction between level 1 and level 2, I think, and the research is showing that too, that as children develop and respond to intervention, they may shift in terms of what level of support is needed. And so that's kind of the positive of moving to this kind of classification system, but there are also drawbacks because it's not always perfectly clear what the needs are.
Thank you. I was about to mention that. So, I mean, maybe at the beginning someone is placed at level 2, but that may change, either go up or go down, right? Is that possible?
And that is possible. So what happens, 20 years ago, we didn't have the full body of research we now have on both diagnostic outcome and response to treatments. And now we have a whole body of literature that talks about what can be expected when early intervention is provided. We also have research that talks about what are some of the, and this is a fancy term, prognostic indicators? What are those things that if they're present when you're young, you get an autism diagnosis and you get an evidence-based treatment, predicts your outcome later. So we have a lot of longitudinal studies to help us understand this. And one of the wonderful things we've discovered is that children may move through that diagnostic criteria system. They may respond really well, become verbal and move along, but have started out at level 2 or sometimes level 3. You mentioned going backwards. A critical question in the autism diagnostic process is, has your child demonstrated regression? So that is a really key piece when we're talking with a parent about their child's development. The autism diagnostic interview is a very structured interview where there are a number of questions going retrospectively. You're looking back during your child's development. We ask that question because if a child's diagnosed autism and regression is present, it tends to be a more impacted autism over the course of the lifespan. We don't see that progression happen necessarily. It also may point to a red flag if it's a female that this could be Rett syndrome, because one of the very defining characteristics of that is you obtain milestones and then regress. You talk, you lose speech, you lose all of it, and it's highly expressed in girls over boys. So this speaks to that importance of a physician really spending a lot of time with you as a parent and making sure that you're engaging in that conversation to give them that information to help parse some of this out. But the good news is that yes, we can see children who start out level 2 are getting a lot of intervention later in school age years. You may not know that they were that impacted because they've responded to those treatments when it's been good evidence-based treatment delivered. And at that point, they may move to where accommodations are needed in school, but maybe not that full level of support that they needed earlier on.
Wonderful. One of my mottos is a diagnosis is not a prognosis. And it's probably the pedopsychiatrist obviously was very angry, it's part of it. And I remember I had the first one, what you said, the non-specified.
The PDD-NOS, pervasive developmental disorder not otherwise specified.
There you go. So that's what he gave me, and I was like, so it just means that they have no idea what my son has. But, I was reading a lot, and obviously, there was so much information, but not as specific as you mentioned right now. And I said, well, you mentioned before, right, that the treatment. And I was told in my days that there was no actual treatment. There was only therapy. Because given the diagnosis, It was just to know that it was a syndrome. So I remember the doctor said, it's not like I'm saying there's something wrong with his stomach and it ends up being the liver. There's something wrong with his development. And regardless of the specificity of the level or the name of it, it is something neurodevelopmentally wrong with your child. And so those therapies that you're doing are good, regardless of the name of the diagnosis. But can you specify that? I mean, so there is treatment and therapies nowadays?
Yeah, and I think that's an important thing to think about because, our words are important. As healthcare providers speak with parents and as parents process this information, the words chosen to describe the needs of a child with autism carry a lot of weight. And so there's been a lot of discussion around a few things. Is intervention the right word? Is treatment the right word? Are supports the right word? Is therapy the right word? And the reason this all comes up is because all of those may have connotations, like you were saying. If you're saying my child needs intervention, you're telling me there's something wrong with my child. There's a perception among many parents that it's not that there's something wrong, but they need supports in order to realize their full potential. And so we talk less about intervention and more about therapy and supports available to your child. Therapy is essentially intervention. It means you're going to spend frequent, intensive amounts of time with a provider who's specially trained to help you learn to communicate, to help you learn to have those most independent behaviors you need to be successful in a school environment or a preschool environment. And what we do know about those supports and therapies is that when they are high quality, rooted in evidence-based practices, and those are very clearly defined. We have a resource called the National Standards Report, and there's another group called the Professional Development Center, and those two organizations have really put together a comprehensive guide as to what has strong outcomes for kids in terms of interventions. When those are all put together, we know that children respond greatly to that. So whether we consider that a support, a treatment, or an intervention really is based on our lens of how we see our child. We see our child as someone who is neurodiverse. The way their brain functions is different. It's not necessarily inherently something wrong, right? When it becomes too difficult to manage, we talk about treatment. We talk about neurologists will talk about, and psychiatrists will talk about medication needs, and that becomes very specific for a very specific purpose. So I think it changes in terms of what a parent is requesting for to help them connect with their child and help their child learn and grow. And that might change over time.
I think that's great. So thank you so much for that clarification. So it's okay to say treatment because, at some point they are taking the medication. The most important thing that I was told is that sometimes when we think of treatment, then we are expecting as an outcome a potential cure, which we don't have.
Yeah,
so
it's not.
That's why people. That's what the doctor said. We avoid using the word treatment. Remember, this is 20 years ago. Well, 16 years ago to be exact. But still, because we are using medications and because we have, so then it is okay to say treatment.
Well, I think it depends on the context. So, for instance, if you have a child with autism who has a co-occurring medical condition that is resulting in seizures, you're treating the seizures. In that case, there is a medication that is being given to treat the seizures that are associated with the autism. And you are correct in that there isn't necessarily a cure for autism. We are learning to treat the associated medical conditions that are highly, highly correlated with autism. And that often is seizure disorder. It might be sleep disturbance, GI disturbance, allergy and immune response differences. And so that's why it's important that your doctor is thinking about what does your child need medically in terms of treatment, and then what therapies may be helpful for your child in terms of their overall development and learning and growth as a child, as a human. This is something that doesn't go away. It makes up who they are. And that's why we do have a different picture of how we think about autism and diagnosing it. It's less challenging to diagnose autism and more challenging to say, well, what does your individual child now need as a result of the autism? And how do we design an intervention plan or a support plan that is going to help your child grow and reach their full potential? So it really involves both the medical providers giving the diagnosis and the therapists and clinicians who will be implementing some of these supports to help your child. And communication and interdisciplinary work that way is really key to giving thorough diagnostic workups and information to families. And it's not everywhere. We know that's not the norm, but that is the ideal condition.
Okay. We use these acronyms and sometimes we're not familiar with this. What are GI disturbances?
Gastrointestinal. So stomach issues. A lot of kids with autism have reflux, and they might have that really early on. That might be one of the first things a mother notices is they're unable to breastfeed and the child is unable to keep food down and there's excessive vomiting going on. And sometimes that doesn't go away. A lot of kids with autism are often on Mylanta or some treatment for this. And that's pretty common, but we have to remember, and that's why that important piece around what other factors contribute, social anxiety and trauma can also introduce those kinds of physical symptoms. So this is why not anyone can diagnose autism. This is why it's important that it's considered in the context of that DSM-5, but also in the context of your medical and developmental history.
Wow. Yes. Thank you for that clarification. And so we mentioned before, but I want to point it in a very specific way about this so-called the comorbid part of it, because with the most important thing about diagnosis is what you mentioned is the level of support. So sometimes the parents, we want to deny it and it's part of our process and all that, but we want to make sure to have the diagnosis as early as possible. And it's great that you mentioned that it can be on the lookout since 18 months and up. So that's wonderful. But not all autism, for example, have intellectual disability. It is
That's
not.
Right.
So it's not to be assumed. So, for example, when I started to look for resources for my son, they had that IQ, and there were some tests, several tests done, and one of them was 7.6 he scored, and then the services there said, well, no, this is only for people who have 7.5 on the IQ level, because I'm not just being autistic. So I had to have all the tests redone because of that number, obviously with the services, they're very picky about that. So can you tell us the most common way that it comes together? And here I want to specify that on my case, now whenever I'm using any services, I ask them first write intellectual disability and then autism, just to make sure that I don't have to worry so much about the interpretation of whomever the new providers are going to be.
Yeah, boy, this is such an important point. And especially as a child's development progresses, what we know is that later in late adolescence, as they're exiting the school system and moving into young adulthood, quite often, in order, as you referenced, in order to get those services, we now have to establish there is an intellectual disability that may be also tied to this. And that's a difficult thing, because when we're looking at, you brought up the point, not all kids with autism have intellectual disability. We know about 40% of children identified with autism will have an intellectual disability. We know that in order to demonstrate that, IQ becomes, it's kind of a question mark for kids with autism, because those tests rely on verbal and nonverbal performance. And you may be impacted by your autism, and therefore it may show those scores being skewed. At the same time, you may be level 1 autism, and you may have an IQ of 130, with 100 being average. You're well above average in terms of intellectual ability, but your autism has you so debilitated with social communication challenges and anxiety that it's as difficult as it might be for someone with an intellectual disability. So what happens is you often have to get another IQ test later before kids move into that adult period in order to establish that they need the services. And so that's where you were mentioning, usually that's a score of 70 is what services are being set at, and that demonstrates that there may be trouble with what's called adaptive skills. Those are those self-help skills for you to be completely independent. And so a lot of times parents do what you're doing, which is don't assume that the autism is the problem alone. Let me demonstrate that there is still a need, because services are as important as you're exiting the school system as they are when you're little in early intervention entering the school system. So it's not like now that all those services have been taken away from us, I suddenly don't have this need anymore. And IQ is one way that people do demonstrate that. There are other tools that are standardized tests of adaptive skills that also demonstrate that need. So without going too far into it, it is important that a psychologist considers both the IQ and the adaptive skills, because those two don't always line up, and adaptive skills are another way of measuring the impact of cognitive ability. It means things like being able to take a bus, tie your own shoes, count money, all those things that you need in order to be an independent young adult in the world. And that can be impacted when there's an intellectual ability challenge.
Right. I mean, it's just sometimes you can count money, but it's such an abstract concept. Like, I'm going to give you a story here. Sometimes you don't really know where they're challenged, and sometimes, like, I assume my son lost his Nintendo. He worked for it. I mean, he had his Nintendo. Now he lost it, and I'm like, how did you lose your Nintendo? No. And he says, it's so expensive. Oh, really? How much is it? Well, it was over $300. That's easy. It's only $300 bills.
Yeah.
Not expensive. It's just, that's cheap. Only $100 bills. So, I mean, it's just, and I'm like, oh, he's right. But that's when but how long did it take? And so I'm now trying to help him understand, because that's how long does it take him? Yeah. Because it's very abstract. So so sometimes, like, okay, back to earth. That.
Exactly.
So with this, as processing the diagnosis, and I think this is very important, that we understand that, and I'm going to emphasize this, it is important to get a diagnosis. It doesn't mean the prognosis is going to be the same. And as we say in the autism community, one person with autism, one person with
One
autism.
person with autism.
Because,
That's right.
on TV now they have all these geniuses and all that, and like, haha. Some people say, have you watched it? I go, no, because it doesn't really relate to me. So,
Right.
With that in mind, what you mentioned that you have to, is there a specific certification, or who should you be looking for to get an actual confirmation of the diagnosis? Because you mentioned that now there is an actual protocol, which I'm very glad is not just clinic observation, but there's also protocol, and soon to have a biological part, which we're very excited about that with this clinical combination. But so what we mentioned about the red flags already, but and you also mentioned that not everybody can actually do the diagnosis. So where and when should we have it confirmed?
Yeah, so I think it's important to understand that a family medicine doctor has the qualifications to give a diagnosis. If a family medicine doctor does that, and a parent says, well, I want a second opinion, or I want it confirmed, it can be confirmed by a neurologist, a clinical psychologist, a developmental pediatrician. They are what we call specialists who are trained in diagnostics for autism. A family medicine doctor is also considered qualified to give a diagnosis. So what it used to be is you used to have to seek out a specialist to get a diagnosis. As you saw, the prevalence rates have been rising over the last 2 decades or so. And what we see is that point of contact is that physician first typically. And so there's been a move by the American Academy of Pediatrics to empower those doctors to be able to make that diagnosis and understand the signs of autism, and also understand what referrals need to be made, because those often are coming from your primary care doctor. So the wait lists to get a diagnosis from specialists is often quite lengthy. So your doctor may diagnose your child. You may still want that confirmation from one of those specialists, and it may be a longer wait time, but your doctor would be able to make referrals in the interim of you even waiting for further evaluation. So there is more latitude for families. What we do know is that an interdisciplinary approach to diagnosis is often the best way, because it reduces time for families to go to these separate specialists. It considers the medical needs alongside the behavioral and communication and language and child development needs. And typically that can be done in a dyad of a nurse practitioner or a clinical psychologist with a speech pathologist, or a clinical psychologist with a developmental pediatrician. And so depending on your community, that's not as widely used. That's more in larger urban areas. But what we are seeing is that parents get more questions answered in a more timely manner when that interdisciplinary model is used. So I guess it's important to know, trust your doctor, but also assure that you've received a comprehensive evaluation for autism, because it informs the supports and the therapies that are needed down the line. If we don't evaluate enough and we just label, that's different. I'm labeling your child, but it's not informing the interventions that are needed. So a comprehensive evaluation helps us understand where the holes are, where the needs are, and very precisely helps you lay out an intervention program and plan, and then able to support the parent in pursuing those services.
Yes, that is very, very important. So, I mean, it's wonderful now that they all have this training, if I may use that word, to have to be able to see it, because unfortunately, the statistics are growing. So
right.
what did you say the statistics are now?
So 1 in 31 in the United States under the age
1
of
in
8.
31, not 33 in 100.
Yeah. No, it's
One?
1 in 31.
Ooh, okay.
And that
Maybe we're
those
taking notes.
those prevalence data are reported by the Centers for Disease Control, and they have surveillance monitoring in states in the United States where that's looked at every 4 years and reported on. So the most recent reporting reported it at 1 in 31. And so that becomes, that's a number where, any given classroom in the United States is going to have at least one child with autism, and the likelihood that they may have more than that are very high. And we have to remember too that a family that has a child with autism is at greater risk of having another child with autism. And that's why when we talk about that criteria and the co-occurring conditions and the genetic component to that, that also becomes important in helping answer some of those questions.
Yes. Well, obviously we in this channel we're very much about the parents and how we feel through this process. So I think knowledge is power, but often we just try to understand too much, and we stop feeling it. So with this combination, so what recommendations would you give to the parents as we are? Wait, before I do that, sorry, I'm going to cancel that. Come back to a very important question. Does the diagnosis need to be updated to get resources? I mean, this is a very important question that I was skipping. I'm sorry, but I come again. Does the diagnosis need to be updated? Say that the child was diagnosed in elementary school, and then or before they enter adulthood. Does it need to be updated?
So in the United States, when services are given to young adults, they do need to be the diagnosis does need to be updated, typically when a child turns 18 or right before the 18th birthday. And the reason for that is a lot of the social services that are provided as a person with autism enters adulthood, they're based on the report of that ability for independence in terms of the intellectual ability, as you mentioned. And then also, if they have that autism diagnosis, sometimes that gives them access to other services. But that cognitive assessment is going to be a key piece to updating that diagnosis. Typically, what will happen is once you've received a diagnosis and it's in the medical history, that diagnosis follows that child throughout their, development. However, it is important because if you're diagnosed at the age of 2 and we're now seeing you at the age of 11, children change dramatically during that period of development. And just because I saw an autism diagnosis in a medical history at age 2, and I'm now engaging with a child who is fully verbal and has friends and playing games and doing all these things, someone may choose not to continue with that diagnosis. And that's really, again, the importance of the parent to talk about, well, do we still have social communication impairment issues? Is there still the presence of restrictive repetitive behaviors? Because we have to remember, to meet that criteria, you need both of those domains met. And so children do change over time, and especially when they're given a lot of intervention and support early on. So I believe 20 years from now, we'll be having this conversation and we'll be talking about how children grow and change when diagnosed with autism, and how we think about their overall trajectory well into adulthood in terms of thinking about treatment, both intervention supports, family support, and social supports, and that's just part of the process of neurodiversity and how children are developing differently from one another. And it's important that we think in those terms, because you're not trying to fix someone or something. You're trying to help that child reach their full potential and also help the family, because I think that's the other piece of this. It's not enough to just give a label and move on. That's kind of the antithesis of what we want to do when we're thinking about good comprehensive evaluation for autism spectrum disorder.
Wow, you just hit a very important nail, right in the head. Thank you for that. And again, diagnosis, not prognosis. And I mentioned this again because some parents just want to, as the longer it takes for them to go to look for the diagnosis and actually accept diagnosis, it is opportunity, the opportunities that they are taken away from their child. So maybe it looked like autism, so start treating it like it, and it could not be, but it's not going to hurt to get those therapies, and might as well, because otherwise
That's right.
get stuck on that. Should you have this, should you have that? So maybe assume that it is, and better find out that it wasn't than the other way around. Am I correct with that?
Well, I think it's important that, when we think about it, at the end of the day, when we think about autism and we think about some of the challenges, they're often rooted in communication and self-regulation and social interaction with others. And if we see a child who's struggling with those things, and there are therapies available to support those areas of development, with or without the autism diagnosis, those therapies are often needed and produce results. And so I agree with your statement that don't let denial drive asking questions about your child's development. It's important to say, I see my child struggling, or my teacher sees my child struggling. Can we look at their development, and is there a need for referral for services? And often starting the conversation that way is more proactive and gets your child what they need, while maybe later figuring out what's going on. But, we learned a lot of lessons over the last 20 years, and hesitancy around the conversation about autism is really looked down upon, because what it's doing is, just as you said, it's preventing that knowledge and empowerment. If your child had diabetes, would you want your doctor not to tell you? You would treat your child's diet very differently if you had that information than if you didn't, but you notice your child's not eating and they're sleeping all the time and they're thirsty all the time. These are the things, it's a way of empowering the parent as opposed to seeing it as a deficit.
Right. Very important. Just to close this, I'm going to give you a little scenario that I actually leave it so that to see what you would tell these parents, okay? I see a lot of parents, and I was at this clinic, and they were seeking for advice, and the father was a military, so they had to move a lot. So it was this child, a girl, so obviously it was a little more evident, and she had hurt her eye, because obviously their level of pain, they tolerate so much pain, unfortunately. Mm-hmm. And so she's moving like this, but she's still. And back in those days, I was still looking for answers, and I said, well, how did you keep her to be still? I mean, I could not keep my son in one place. And the father very proudly said, we just won't listen to whatever they tell us. We just don't listen. We just treat her as if she were a normal child. I was like, ow. I'm going to pause here. What would you tell those parents?
Well, I think it's important to think about Well, I think it's important. There's a few different ways to look at this. The idea that they're holding the expectation for their child that they would for any other child helps that child to reach that level of potential. We do see where some parents will try all these different approaches and it's inconsistent and the behavior is still challenging. At the same time, there are behaviors that may require special attention and a special approach. I think it's important that if a parent feels that their child is being successful and that approach is working, to the point where you even noticed and commented on this, then we'd say, keep doing what you're doing. If you need additional support, there are specific things that we can do for specific behaviors, but holding that expectation, may be a good thing. At the same time, some parents, their standards are too high and the expectations, the child is not able to reach those. And so sometimes those demands are not in sync with the child's ability. And so I think a parent coaching model that is specific to their child is how we answer those kinds of questions or, let parents know whether they're on the right track or not.
Wonderful, wonderful. Yes, I remember I gave the doctor a big test, for all his abilities. And I said, I want to know what he can do and what he cannot so that I don't want to demand too much of him. Yeah. And at the same time, I don't want to lower the expectations and, put the standards so low. So I gave him this big, huge, expensive test that I had done. And I gave it to the doctor. He just browsed through it and he says, okay. So tell me, what is too much to ask of him and what is too low? He says, you don't know. Just ask him to do it. Demand of him as much as you can. Right. And if he doesn't do it, then he can't.
That's right.
Try something else. Yeah. So I said, if I spent all this money doing this ability test and all
this analysis, right? There's something in child development called the zone of proximal development. And it's this notion that you do exactly what was suggested. You put the demand slightly higher than what you think they might be able to do, and you're within a zone where they might be able to do that. If they can't, you offer the support. So what you're doing is you're kind of always going alongside, right behind, ready to catch them if they fall, right? The idea is you need to give them the opportunity to try and to fall, and you will be there to catch them and to help them if that's the case.
I like that, to be able to catch them. Thank you. Thank you so much. How would you like to close this?
Well, I'd like to thank you for what you're doing for all of the parents of kids with autism. And I really commend the effort to help families understand and better understand autism in the process. I will say that I agree with your notion that knowledge is power. And the more that you can learn, both from your child as well as from resources that are available to you, your child is often your greatest teacher. And you as the parent know your child best. So to help that process, you are the person who is in control of helping share that information and helping those doctors arrive at those decisions. So don't underestimate your own knowledge and your own understanding of your own child. It has been an absolute pleasure to talk about autism today and to celebrate autism, because the kids that I've been involved in when they were little, 2 years old, and working with those families, and I know them now as 26, 27-year-olds, it's unbelievable. And those parents who are like you, Elvia, who push their child and can see the strength in their own child, you're constantly helping them to grow and develop. And at the time, you don't realize it. You're planting a seed and you're hoping that flower will grow, as I've said before. And you're a parent now who has all of that hindsight and knowledge behind you. And I think of the parents who are just starting out and how valuable this is. So thank you for what you do.
Well, thank you for being willing to share your vast knowledge, because you're such an asset and I so much appreciate it. So yes, we just in the journey together, and we just need to ease the way for other people. So I appreciate it. Thank you.
That's right.
Thank you so much.
Thank you, Elvia.
Well, I want to thank Georgina for her time, and she's so generous, and she's a very, very dear friend. I always tell her that for me, I was dragged into this journey, of the world with autism, and but with her heart being so generous, she helps us without it being part of her life. She just became with her career, and sometimes she says that she breathes and learns with us. She learns with autism. So I really want to thank that. And also, she has shared some very important links for resources that I'm going to put in the description. Please make sure, if you want to know more about the red flags and you want to learn more, feel free to press those links, and they're going to be very, very important resource for you. So thank you for staying this far. Thank you for listening. And remember, you're not alone. God loves you. Thank you for staying. Bye.